Major adverse cardiac events, or MACE, are estimated to occur in 5% of patients undergoing non-emergent, non-cardiac surgery. My name's Michael Mueller. I am a senior associate consultant in the Division of General Internal Medicine at the Mayo Clinic in Rochester, Minnesota. Our paper, Perioperative Cardiac Risk Reduction in Non-Cardiac Surgery, will occur in the August 2021 issue of Mayo Clinic Proceedings. In our paper, we summarize strategies to mitigate risk of MACE and myocardial injury after non-cardiac surgery, or MINS. First, we discuss the optimal timing for non-emergent, non-cardiac surgeries to minimize the risk of MACE. We recommend increasing the time interval between myocardial infarctions and non-cardiac surgery, ideally to 60 days if possible. Patients who had an MI prior to non-cardiac surgery do show decreased mortality and decreased risk of reinfarction if they were revascularized prior to surgery. For patients requiring a non-cardiac surgery within 30 days of an MI, consider a balloon angioplasty, for which only 14 days is required between the MI and the non-cardiac surgery. This should always be followed with a definitive intervention for revascularization after the surgical period. For patients who need non-cardiac surgeries in 1 month, patients who have received CABG have better outcomes than those who have received percutaneous coronary interventions. Make sure to wait at least 30 days after CABG for stable ischemic heart disease before proceeding with surgery, and 60 days for CABG due to an MI. For those who have received stents, surgery can be considered 30 days after deployment of a bare metal stent. And for patients who have received drug-eluting stents, surgery should be delayed for at least 3 and ideally 6 months. Myocardial injury after non-cardiac surgery, or MINS, is characterized by asymptomatic elevations in cardiac biomarkers such as troponins. It does not cause EKG changes, and it is common. MINS is associated with increased 30-day mortality rates after non-emergent cardiac surgeries, and therefore we recommend screening for it. The Canadian Cardiovascular Society recommends screening patients who are at high risk for MINS with a proBNP. If the proBNP exceeds 300 in the preoperative period, patients should be monitored more closely in the perioperative and postoperative period, and consideration should be given to ordering cardiac biomarkers such as troponins. If MINS is found in the perioperative period, close cardiac monitoring is warranted, and some experts recommend initiating aspirin and statin in these patients. Congestive heart failure is a major risk factor for MACE and is associated with increased mortality after surgery, regardless of whether or not ischemic heart disease is present. Mortality is increased in patients with symptomatic heart failure and patients who have heart failure with reduced ejection fractions. For patients with newly diagnosed heart failure, we recommend delaying surgery for at least 3 months. For patients with known heart failure, we recommend obtaining a transthoracic echocardiogram and a proBNP prior to surgery. Some major organizations even recommend using a proBNP for screening patients who are at high risk of having heart failure, such as patients with coronary artery disease, severe structural cardiac disease, or an age greater than 65. Hypertension is common in the perioperative setting. Diastolic blood pressures greater than 110 are associated with worsened perioperative complication, and we recommend delaying surgeries if patients have blood pressures greater than 180/110 in the preoperative period. There is little data to suggest that controlling blood pressures to less than 180/110 decreases complications, and we recommend avoiding over-controlling blood pressures due to the risk of organ hypoperfusion. Avoid starting new blood pressure medications immediately before surgery. Postoperative hypertension is also common. For systolic blood pressures less than 180, permissive hypertension is acceptable within 3 to 5 days of surgery. Hypertension should be treated if systolic blood pressures are greater than 180, or if there's evidence of stroke, MI, heart failure, or aortic dissection. Avoid rapid blood pressure shifts. We recommend reducing blood pressure by 25% in the first 24 hours. Arrhythmias are common in the perioperative setting. We recommend delaying non-emergent, non-cardiac surgery for patients who have new diagnoses of preoperative atrial fibrillation. For patients with known atrial fibrillation, we recommend managing heart rates to a goal of less than 110 beats per minute. Post-operative atrial fibrillation is also common. For patients who are stable, rate control with a beta blocker or a non-dihydrogen non-dihydropyridine calcium channel blocker is appropriate. All patients with postoperative atrial fibrillation should receive outpatient surveillance to look for persistent atrial fibrillation. And for patients with frequent postoperative atrial fibrillation or atrial fibrillation lasting greater than 48 hours, consider 30 days of postoperative anticoagulation. We also reviewed many medications that act on the cardiovascular system. Full recommendations on management of these medications in the perioperative setting can be found in our paper. Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.